just want you to remember 5 basic important things. Radioactive iodine ablation, what we are going to use this, how we are going to use this, what are the side effects, what is the rationale behind using this. It will be useful both for your theory and practicals. So radioiodine ablation, dosing guidelines for remnant thyroid ablation 75 to 100 microcurie, for positive lymph nodes 125 to 150 microcurie. In case of lung mets and bony mets 175 to 200 microcurie. For recurrent disease it is 200 microcurie, or it may be more than 200 microcurie. And in case of radioactive iodine, for low risk and young patients there will be a low dose ablation which will be 30 to 50 microcurie. For high dose ablation it will be for high risk patients 100 to 150 microcurie. So what are all the precautions if you are going to give iodine 131 for thyroid carcinoma patient? First 5 days after therapy for radiation safety is very important, right? So the patients receiving the iodine 131 should not contaminate others with urine, saliva or sweat, and they should not become pregnant for at least 12 months. They should discontinue breastfeeding, maintain low dose iodine diet 3 days after therapy, drink more fluids, uses bathroom very frequently for the first 2 days, and sucking candies which will prevent the sore throat and injury to the salivary glands. Gentle brushing of entire mouth with a soft brush 6 times per day. Do not share food, dishes or any glasses. Wear disposable gloves if preparing food for the other people. Avoid open mouth kissing and sex. So what are all the side effects of radioactive iodine ablation? Acute side effects: neck pain, swelling, tenderness, thyroiditis if remnant is present, cyanidinitis 50 to 450 microcurie, cerebral edema in case of brain mets and 200 microcurie, vocal cord paralysis, nausea and vomiting, bone marrow suppression 200 microcurie, long-term side effects: bone marrow suppression more than 500 microcurie, leukemia more than 1000 microcurie, infertility, increased risk of spontaneous abortion, puerperal sepsis, anaplastic thyroid cancer, gastric cancer, lung cancer, breast cancer more than 1000 microcuries, and bladder cancer. TSH suppression reduces tumor recurrence. We have to maintain the TSH level less than 0.3 to 2 microunits per ml. Low risk of recurrence. If TSH 0.1 to 0.5, high risk of recurrence will be there. So if uptake present on follow, you should give iodine 131 150 microcurie. After that you measure thyroid globulin, then you should do whole body scan, and then suppressive dose of thyroxine 200 to 250 microgram daily should be given. So what are all the modalities of treatment for thyroid cancer? Surgery, radioactive iodine ablation, external beam radiotherapy, thyroxine therapy, chemotherapy. Tissues that take up iodine 131 falsely misconceived as mets, like salivary gland, esophagus, thymus, bladder, colon and breast. So what is the rationale in behind performing radioactive iodine ablation? Eliminate post-surgical thyroid remnant, microscopic foci of carcinoma cells within thyroid remnant, facilitate the detection and early treatment of persistent and metastatic disease in absence of normal thyroid tissue. ATA recommends radioactive iodine ablation compulsory for known distant mets, for gross extrathyroidal extension, for primary tumor more than 4 cm. Recommend radioactive iodine ablation recommended for selected patients in 1 to 4 cm thyroid confined to thyroid, lymph node mets, gross or microscopic multifocal disease, intrathyroidal vascular invasion. Prerequisites for performing radioactive iodine scan: the TSH should be more than 30 milliunits per liter to stimulate the uptake of iodine, and it will be increased by either recombinant TSH or withdrawal of thyroid hormones for 6 weeks prior to ablation. Isolation of the patient, hospital accommodation with the private toilets, Avoid iodine containing foods and medicine before ablation. Iodinated contrast, CT preceding 3 weeks. Uh, Lactating mother, stop feeding. So, very important is radiation ablation is not recommended in unifocal cancer less than 1 centimeter without high risk future. Absolute contraindication: pregnancy and breastfeeding. Relative contraindication: already there is a bone marrow depression, severe liver and kidney failure. Pulmonary function restriction. Iodine 123 T of 18 hours. Iodine 123 emit only gamma rays, which is useful for imaging. Iodine 131 T of 8 days. It will emit gamma rays, it will emit beta rays. 10% it will emit gamma rays for imaging, 90% beta rays for therapeutic imaging. Iodine 131, which is oral injection. Liquid is available in liquid form and capsules form. Each capsule 50 microcurie. Capsules are safer than liquid as less radioactivity released into the hair. Capsule causes less oral mucosal irritation. Radiation ablation useful in only differentiated thyroid cancer like papillary and follicular, not used in anaplastic and medullary thyroid cancers. So, what is the steps that we use to treat radiation ablation? 1 to 3 microcurie of iodine 131 given, followed by pre-therapy scan 24 to 72 hours late for residual iodine uptake by thyroid tissue. Therapeutic dose of iodine 131 given. Thyroxine regular diet 2 days after therapeutic dose of iodine 131 given. Whole body scan after 1 week post therapy scan. Identify the metastatic disease. So, if it is a successful therapy, it is absence of visible radioactive iodine uptake on diagnostic scan, undetectable thyroglobulin. Diagnostic scan done 3 to 6 months post therapy. Subscribe at Inspired Surgeon. Time management is very important in your exam. Disclaimer is given in the description. If you want any topics to discuss as a precise and short, let me know in the comments. Thank you.